Thank you all for having me. I know this is a talk on locally advanced non-small cell lung cancer in the early stage section, but hopefully some of you will find this of interest. Next slide. So how can we improve overall survival in the locally advanced setting? I'll pose the question, has photon radiation reached a plateau in stage 3 non-small cell lung cancer? And what is the rationale for proton radiation therapy? What is the pilot experience, and what are the ongoing clinical trials evaluating proton therapy in stage 3 non-small cell lung cancer? And lastly, because protons are a limited resource, we need to look at how we can continue to innovate with photon-based radiation. Next slide. So this is the down one. Okay. Thank you. So this is a timeline of median survival for locally advanced stage 3 non-small cell lung cancer, and I have plotted several pivotal cooperative group studies. If you look at RTOG 7301, comparing 40 versus 50 versus 60 gray, median survival was 12 months for the 60 gray arm. We then evaluated sequential chemoradiation relative to radiation alone. We improved median survival to 14 months. Then 9410 looked at concurrent chemoradiation, and we saw improvements in median survival to 17 months. Recently, RTOG 0617 compared 60 gray to 74 gray dose escalated radiation. As we all know, the control arm won out. It did do very well with median survival of 29 months. How do we explain this improvement of 60 gray relative to 9410? You can say much of this is based on PET staging, but I also would make the argument that improvements in radiation technology may be playing a role. In 2005, CT-based planning and 3D radiation became standard of care, and we know that this does improve survival relative to 2D-based radiation. In 2010, there was increased use of intensity modulated radiation therapy, and right now in 2015, we're evaluating protons as a potential mechanism to continue to improve median survival for this patient population. So this is a survival curve for RTOG 0617, which we saw at ASCO several years ago. Again, the 60 gray arm won out with a median survival of 29 months relative to 74 gray with a median survival of 20 months. Despite being a negative trial, we did learn important information on multivariate analysis. Importantly, the heart dose, including the V5, which is the volume of the heart receiving 5 gray or more, as well as the V30, were significant factors for decreased overall survival. And really, before this, we didn't appreciate that the heart dose could impact survival. We knew that from the breast cancer literature that increasing dose to the heart did contribute to late effects 10 to 15 years after radiation, but this was really sort of a novel finding, and it wasn't appreciated before this study. Now, when we talk about optimizing radiation for the locally advanced stage 3 non-small cell lung cancer, we have to consider photon radiation and 3D conformal radiation relative to intensity modulated radiation therapy. There have been recent subsets from RTOG 0617 looking at IMRT. One published in JAMA Oncology recently showed improved quality of life for IMRT compared with 3D conformal radiation. And at the World Lung Cancer meeting, we saw that the IMRT cohort in 0617 had reduced rates of grade 3 pneumonitis. So I think just along the photon spectrum, we are seeing improvements with intensity modulated radiation relative to 3D conformal radiation. However, we don't have any randomized data to prove this. So what is it about protons that makes them so appealing for the treatment of thoracic radiation? It all relates back to the depth dose curve. Now, if you look at the proton in red, the proton deposits its dose at the maximum range of the proton, and then the dose falls off sharply. This is referred to as the Bragg peak. A photon, in contrast, has a much larger exit dose, and this essentially increases the total integral dose to the patient, deposits more dose in the uninvolved lung as well as the heart. So the pilot studies for proton radiation really came out of MD Anderson. This is a phase 2 study that was published in Cancer in 2011, This is 44 patients. They treated them to 74 gray with weekly carbotaxol, and median survival was 29 months, essentially the same as RTOG 0617, the control arm. Toxicity was quite low. Grade 3 esophagitis was only about 10%, and grade 3 or higher pneumonitis was only 2%. So these results were very promising. This is also retrospective data from MD Anderson looking at over 500 patients treated with concurrent chemoradiation. They looked at the mean heart dose. Patients with a mean heart dose over the median are plotted in the solid line, and less than the median is in the dotted line. And you can see there's trends towards reduced survival in patients with a mean heart dose over the median. It became statistically significant in the 68 to 70 gray dose cohort, and it was significant on multivariate analysis. So this is really telling us again that the mean heart dose matters, along with the V5 and the V30 that we saw in RTOG 0617. Again, data for MD Anderson looking at the mean heart dose for patients treated in the different dose cohorts. You can see the mean heart dose is decreasing with IMRT relative to 3D, and it further decreases with protons relative to IMRT and 3D. This is a pictorial representation of what the radiation dose distribution looks like for 3D versus proton-based radiation. You can see on the left with 3D conformal radiation, there's much more dose going into the contralateral lung. There's more dose going anteriorly into the left ventricle. With the proton-based radiation, the dose is more conformal. We have less contralateral lung radiation, and importantly, less heart radiation. So this is data from an ongoing bi-institutional study with MD Anderson and Mass General. This picture on the left is plotting the mean heart dose for patients getting IMRT in this trial versus protons. The red proton group, you can see the mean heart dose is again lower. So all of this data was really the impetus for the ongoing RTOG study that's an NRG oncology study. This is 70 gray given with photons versus 70 gray given with protons. The concurrent chemotherapy is either weekly carbotaxol followed by consolidation carbotaxol or cisplatin and etoposide. And the hypothesis for this study is that proton-based radiation will improve overall survival, median overall survival from 21 months to 30 months by reducing toxicity to the heart and the lungs. Now, this study was activated in 2014. As of last week, there were 56 patients enrolled. We're looking to enroll 560 patients. So it's accruing, albeit slowly. Obviously, one of the factors that contributes to this is that protons aren't available at every center that would typically enroll into RTOG studies. But I think we still need to ask the question, can we spare normal tissues, manage the heart dose, and improve overall survival by optimizing our photon-based radiation? Because in the end, protons are very expensive. They're located in urban centers. Patients that live in rural communities may not have access or resources to go to a proton center. And the financial toxicity, I think, is considerable. So the RTOG is looking at hypofractionated adaptive radiation with an in-treatment PET. This is the schema for a relatively complex study, RTOG 1106. Basically, patients are getting 6 weeks of radiation, and after 18 or 19 fractions, they get an in-treatment PET scan. One arm is continuing radiation. The other arm gets an adaptive boost that's based on the during treatment PET positive volume, and the total dose is escalated up to 80 gray based on the ability to meet normal tissue constraints, including a mean lung dose constraint of 20 gray. The study is enrolling, and I think it could be an alternative to proton-based radiation for centers that aren't treating patients with protons. But it is an interesting question, and we'll be looking for the results of this once this meets accrual. So again, this is a dose escalation, but it differs from 0617 in that PET-based planning is required. The duration of treatment is limited to 6 weeks as opposed to 7.5 weeks. And there's 4D CT requirement, and motion managed treatment is required, which was not required in 0617. This is a picture of a patient that is enrolled on 1106. You can see that this patient had a significant response in the lymph nodes on their during treatment PET scan. So just briefly, I wanted to mention non-small cell lung cancer and stereotactic radiation. We know that stereotactic radiation has improved treatment outcomes for medically inoperable early stage lung cancer patients, but can we use this technology for patients with locally advanced disease? SBRT is more effective because you can deliver a more intense or a more biologically effective dose. With SBRT fractionations, the BED is reaching levels of 100 or greater, and we're not really able to do that with conventional fractionation. And our Japanese colleagues have shown us that if we can reach this BED of 100 gray or more in the early stage population, we're seeing improved survival. So at Emory, we asked the question, can we use SBRT in locally advanced patients? We designed a phase 1 multi-institution study. We're giving 44 gray with weekly carbotaxol, and then we are doing a second simulation and doing an SBRT boost to the remaining gross disease within the primary lung as well as the mediastinum. The SBRT boost is dose escalated, and again, our primary endpoint is to find the MTD for the SBRT component of the treatment. I'll skip this in the interest of time. This is the patient we had on one of our first dose cohorts. This patient had bulky AP window lymphadenopathy, underwent 44 gray with the weekly carbotaxol, and then an SBRT boost, 9 gray times 2 to the primary and the mediastinum, and did have an excellent response with minimal toxicities, no grade 3 toxicities. So in conclusion, I think we can say that overall survival has improved over time for stage 3 non-small cell lung cancer. I think that IMRT may be beneficial relative to 3D conformal radiation. Again, we don't have randomized data to support this, but we have compelling subset analyses. The preliminary proton data does appear promising, but again, protons are a limited resource. And we need to continue to optimize our photon-based radiation treatment, again, with an emphasis on normal tissue dose reduction, particularly the heart. Thank you.
Question, very nice. The heart dose, though, seems like it might be a confounded parameter because it also reflects tumors that are more invasive into the mediastinum and,
yes.
and higher T-stage tumors.
And more multi-station
correct.
Node positive
and so
disease.
That seems like it's intrinsically confounded, and it might just be true and unrelated.
Yes, no, I agree with you. That's a very good point.
Kristin, nicely done. So in 617, the control arm ended up outperforming the experimental arm significantly with a survival of 28 months, 29 months. In the photon versus proton study, your control group, you're expecting that to drop back to 21 months. So.
I know. I think many people have questioned the hypothesis of 1308. You know, and the fact that we're looking at 70 gray, which we sort of proved that 74 was not as good as 60, so why aren't we looking at 60 gray? Those are all sort of issues, I think, that will ultimately be criticisms of this study.
And why do you think the improvement occurred in 617 in terms of the survival?
Well, I mean, I think it was, you know,
radiation techniques
PET-based staging. You know, a lot of the stage 4 patients we identify now, we didn't identify them 10 years ago. Also, again, I mentioned the 3D planning. There's a SEER study that shows 3D planning improves survival relative to 2D planning. In RTOG 9410, 3D planning wasn't required, so there were patients that were treated with more of those 2D large fields, and you know, as the radiation fields get larger, our toxicities increase. So I think our technology is improving, and that may have something to do with it.